Well, you know, there was no one singular event that I thought, you know, when I was a child, I had a dog that was sick or something like that, that precipitated any thoughts about going into medicine. To be quite frank, I was in my fourth year of undergraduate work, and I had to do something. And I thought about going into English as a profession, teaching it. And I talked to the people in the English department, and they asked if I had any other thoughts besides English. They probably didn't want me to come into the English department. And I said, yes, I thought about medical school. I mean, it was in the back of my mind. So they said they thought that might be a better choice, to go to medical school. So I was late actually in applying for medical school in my senior year. And I decided to apply, and I was accepted. And that really started the ball rolling. And I must say, I have never regretted that decision. I felt, at least for me, that medical school has been, in medical profession, has been really kind of the quintessent specialty. And so after I made up my mind, then I applied myself, to, number one, get through medical school, which is always a worry the first year you start, and then to graduate and go on to some specialty. So medical school, I actually split my 4 years, and the reason I did was North Dakota has at that time a 2-year medical school. So you take your freshman and sophomore years there, which at that time was considered the basic science years. And that was medical school when I started, and that would have been 1955, was split into 2 segments: the basic science years, 1 and 2, and then what we call the clinical years, years 3 and 4. And North Dakota wasn't able to support a clinical program at that time. They just did not have the facilities, nor did they have the money. So we all had to transfer to other medical schools. So sometime in our second year, usually at the beginning, we applied to 4-year medical schools. And that was another anxiety-producing situation, because in the sense you were being admitted to medical school for a second time. So you had to go through that process of reevaluation. It was based on 1-year study at North Dakota, excuse me. And so we all had a lot of anxiety about it. But then I was accepted at the McGill University in Montreal, and spent my last 2 years there. Now, there was a quantum difference between Grand Forks and Montreal, as you can well imagine. Grand Forks at that time had about 45,000 residents with East Grand Forks, whereas Montreal was a city of about 2 million people. It was a metropolis, and a very cosmopolitan metropolis with very large hospitals. And I must say, the first day I arrived in Montreal, I knew I would never go back to Grand Forks. That convinced me that I really preferred a big city. And it was, for me, it was a really kind of a wonderful experience. It's 2 years that I think helped shape me both as a physician and as an individual. And it was just the ambiance of the city and the medical community at McGill were incentives really to achieve. And I thought it was one of the better choices I've ever made in my life, as a matter of fact, to go to medical school there. But then after 2 years, I kind of had to make up my mind whether I was going to stay in Canada and probably eventually become a Canadian citizen, or whether I was going to return to the United States. And I decided to return to the United States. And I came back to the old Anchor Hospital in St. Paul. I don't know if you ever heard of it, but it was the old city-county hospital on West 7th Street. And it was a monument to the hospitals. There were several buildings. Many of them were 60 and 70 years old. I mean, they were well kept up, but they were very old buildings. And Anchor was I thought, a very good learning experience. It kind of enabled me to pull together all of my training that I got in medical school and put it to clinical use. And it was, I think, both rewarding and an eye-opener, because as a student, you don't really have to assume a lot of responsibility for an individual patient. As an intern, you're not ultimately responsible, but you are responsible for the well-being of patients. And if you make a mistake, I mean, the patient may die. So you tested your clinical skills, and I think also your moral behavior, I mean, during that period. And the supervision was close enough that we weren't just allowed to go off on our own and do whatever we wanted. We had to toe the mark, but we were given a fair amount of freedom. I mean, and that freedom, I felt, could be dangerous. You have to exercise it with a great deal of discretion, because in medicine there's a moral imperative. I mean, and you've all heard it. I mean, you do no harm to the patient. And if you do, it's inadvertently, that is. You never do it overtly. But if you do it inadvertently, it can be a devastating personal experience. Being an anchor for the one-year internship, I transferred to the University of Minnesota postgraduate training program in pathology. And when I arrived in Minnesota in 1960, there were actually 2 separate departments devoted to pathology. And Dr. Benson may have mentioned this to you. I don't know if he did or not. There was a department of pathology which was headed by Dr. James Dawson, and that was referred to as the anatomic division. And there was the laboratory medicine, in which Dr. Benson was located at that time, which was headed by Dr. Gerald Evans. And Dr. Evans was kind of an old school, scholarly type of individual. He actually went to McGill as well. And he was kind of bombastic in many ways. And he could be rather frightening, but after you got to know him, he was really a very kindly individual, a very gentleman type of individual. And he was the head of the department when I first arrived and during my entire training period. And then after I finished 2 years in the anatomic department, Dr. Dawson's department, I transferred over to laboratory medicine with Dr. Evans and spent 2 years in that department. Shortly after that, then Dr. Benson became head of the department in laboratory medicine, but it still remained as 2 separate units. So being in one did not mean automatic entree into the other section. I mean, you had to bargain for 2 years in one area and 2 years in another area. I don't recall anybody who was rejected, however, from doing both programs. But once again, there was a little bit of anxiety associated with that. But it was during the 2 years of the laboratory medicine that I more or less decided to go into hematopathology. And that's where I began my specialty training. Now at that time, laboratory medicine was a much smaller, but they had some very good individuals who were 1 or 2 superstars, as a matter of fact, in their field. And one of them was in hematopathology, and that was Dr. Dorothy Sonberg. And Dr. Sonberg had been at the university at that point probably since about 1948 on the faculty. And this was now 1960-some, 64, 65. So she had been a long-term member of the faculty of the University of Minnesota. And it was with her with whom I began my training in the hematopathology. She was a well-known bone marrow pathologist. So I began my training with her and stayed with that program as a trainee for about 2 years. And then in 1967, I went on the faculty myself. So that really began my career in hematopathology at the U. This would have been the late 60s, early 70s. And at that time, the way to diagnose disease, I would say, was rather primitive by comparison with what we have today. We relied solely on looking at a microscope with a few what we call cytochemical stains. And despite the fact that we are further ahead in diagnostic tools, we didn't make a lot of mistakes, I might add. In many of the conclusions that we reached about treatment, particularly of leukemia in children, what we refer to as acute lymphoblastic, were based on treatments that were began back in 1965, 1964. And the prognosis of individuals who were treated starting about 1966 improved remarkably. Now, prior to that time, I would say prior to about 1962-60, the treatment was really consisted of 1 or 2 drugs. And we did get responses, but they were somewhat limited, except in a few children. A few children got better, and they seemed to, in a sense, be cured. And we didn't totally understand that at the time. And then in the late 60s, early 70s, newer drugs began to be introduced. And although the diagnosis was based at that time only on looking at slides under the microscope, we began to establish patterns that if it looked this way, there was a very good chance that that child was going to go into long-term, what we call remission. And nowadays we would say a cure. So the evidence of curing acute lymphoblastic leukemia in children, which was a very exciting moment, really began in the early 1970s. Now we've improved it since that time with newer approaches to therapy, but the difference is nowhere near what it was, say, from 1955 to 1965. I mean, I was recently at the funeral of one of my former colleagues, memorial service, and it was Dr. William Crippen, who at the time I arrived at the university was a head of pediatric hematology. And the treatment for acute lymphoblastic leukemia when he arrived was still very tenuous. At his memorial service, one of his former patient's father got up and spoke as a tribute to Dr. Crippen. And he spoke about, he brought his son over to the hospital, another hospital in the city, first of all, excuse me, and the diagnosis was made of acute lymphoblastic leukemia. And they told him, there's nothing we can do. You might as well take the child home because there's absolutely nothing we can do. And at the memorial service, he spoke of this extremely devastating experience. Here was his 7-year-old son, just at the beginning of his life, essentially, who had a diagnosis which he was told was going to be the cause of the boy's death in a very short period of time. So as soon as they got home, he called Dr. Crippen. And Dr. Crippen told him to come over to the hospital immediately, which they did. And Dr. Crippen started him on a new regimen that was just being introduced. and the boy went into a complete remission. Now, it didn't last forever. It only lasted for about 12 months. And eventually the boy did die. But the father spoke of the hope that he received from Dr. Crippen and what an experience that was, even though they only had 1 or 2 more years of life for the boy. Nevertheless, he said that was like a lifetime, I mean, to have the boy around for another year or two. And incidentally, as part of that, he said that his second son then grew up, went to medical school, became a physician, and became a cancer therapist himself. He's presently a radiotherapist in Denver, Colorado, at one of the major institutions there. So he spoke of an era, maybe it really demonstrates the splitting, told by one group, nothing we can do, and told then by Dr. Crippen that there was something we could do, at least it would be temporary, and that the boy, he couldn't predict the long-term survival. But I think it's kind of a example of what we were going through at that period of time. We were seeing patients who otherwise might seem hopeless 10 years earlier, but now there was a glimmer of hope. Now that isn't true, by the way, for all types of leukemia, but it is very true for this type of leukemia in childhood, that today 85 to 90% of children between the ages, say, of 14 years can be treated for acute lymphoblastic leukemia, and essentially they're cured. So it's been a remarkable progress, actually, since I started in the field in 1960. Now, in other areas, it's not quite as optimistic. I mean, in the late 60s, early 70s, they tried a lot of new drugs for another type of leukemia called acute myeloid. And there is some progress in that area, but it is nowhere near as dramatic as the treatment for childhood leukemia. So in a sense, I had the opportunity to live through an era of development of therapy for acute leukemia, which has been fairly remarkable, to the point where about 4 or 5 years ago, maybe 6 now, a new agent was introduced for a disease called chronic myeloid leukemia. And the disease, which formerly had a median survival of about 2.5 years, now can be treated with a patient going into remission, and we don't know how long those remissions are going to last. Now, they don't all stay in complete remission, but I would say maybe 85 to 90% will be in remission for a very prolonged period of time. So once again, it illustrates a progress that has occurred in this field. So I've had the opportunity, and I feel it's been a great privilege, actually, to be in a field which has progressed so remarkably. By the way, that isn't to indicate that other fields of medicine aren't similar to this, but it's a field where the results are so dramatic, I mean, that it's easy to point them out. I mean, you could say the same thing about cardiac disease or kidney disease with transplants, but I just happen to be in a field I liked very well. But during the period I mentioned Dr. Crippen, Dr. Crippen was kind of an intellectual wild man. He could be very bombastic, and he could fly off the handle, so to speak, very quickly. But the next moment, he was a very friendly individual. And he was already on the staff, and I was just in training. So he first started out as somebody who was, in a sense, my superior. But we became very good colleagues over the years. And he was very supportive of my progress in the department. Another individual who died about 2 years ago, all my colleagues are dying, was Dr. B.J. Kennedy. And I mentioned Dr. Crippen was in the pediatric service. Dr. Kennedy was the head of the adult oncology service, which was responsible for treatment of tumors or cancer in the adult population. And he was a real superstar. He introduced several new types of therapy for testicular carcinoma, for acute myeloid leukemia, and for chronic myeloid leukemia. And he had a big ego, but he was a very, very nice person, and he was extraordinarily compassionate with patients. I personally observed him, talking to patients, not trying to deceive them about their prognosis, but to be frank, but also to be understanding and compassionate. And I thought it was a remarkable trait in a cancer physician, because the patient, I think, has to be told what the situation really is. You have to gain their trust. And the only way you can gain their trust actually is being totally honest. But he held out promise where there was promise. And the patients trusted him both, for the type of treatment that he gave, and I think in their personal lives as well. So he was a very big influence, actually, on many trainees at the University of Minnesota in the internal medicine service, just as Dr. Crippen was in the pediatric service. Also in pediatrics, there was a contemporary of mine in regard to stage of training, Dr. Mark Nesbit, who also became a leukemia therapist and developed a national and international reputation. And what it kind of illustrates is that in an institution like Minnesota, you have several people in different departments who are developing simultaneously. And if they create the opportunity to really achieve something. And in the 70s and 80s, it was kind of a golden period at the University of Minnesota, both within our department and within the oncology services, both pediatric and adult. We had many excellent individuals, young, contemporary of mine, who were developing just as I was. They were aggressive. They wanted to achieve. And at times it was, could be a little bit of an irritant. If you felt you were being upstaged for some reason or other. But the competition was very beneficial. It wasn't destructive. And it gave us all the opportunity to develop national and international reputations simultaneously. That is, I guess what I'm saying is here I have an international reputation. I'm not sure that that's true, but what I'm saying is the opportunity was there because of this collaborative spirit of Minnesota. And it was well known around the country that this existed in Minnesota at that point. So I always felt the 1970s, 1980s were probably the highlight of my intellectual experience at the university. And we did a lot of writing. We made some, what I thought were interesting observations. Whether they were important or not, I think time will tell. But to me, at least, they were intellectually stimulating. And it was the ability to discuss these with other people in the institution. I think that always made life very interesting. When I was getting ready to retire, one of my internal medicine colleagues said, would you do anything differently, or would you do it all over again? And my reply was absolutely no doubt that I would do everything. I hope I wouldn't make the same mistakes. We all make mistakes and they're unavoidable. But I would there wasn't a day that I went to work that I didn't want to go to work. And I think that's a remarkable statement to make. I mean, that you enjoy your work that much, you never regret. And I was talking to an ophthalmologist friend of mine just last week. And we were both from North Dakota, and so we were kind of reminiscing. And I think we both agreed that it was the best life that we could have chosen. He actually started out as an undertaker. And he worked as an undertaker in Montana, and then decided he wanted to go to medical school. So he returned to North Dakota and went to medical school, and then eventually became an ophthalmologist. But we both agreed that it was a wonderful life, which it has been. Now I can illustrate some other colleagues. The ones I talked about were outside the department. And I'll go inside the department, and I mentioned Dr. Dorothy Sonberg, who was my mentor for many years. And Dr. Sonberg actually started out as a PhD, and then she got her MD. And she was a superb morphologist. And I think it was due to her that I learned the discipline of looking carefully. She was a very careful observer. And to her, the worst possible mistake you could make was to make a mistake in diagnosis of leukemia. So she kind of instilled in me excellence in diagnostic work. In medicine, that's critical. I mean, if you begin to fool yourself and think you're better than you are, then you're going to do things that you shouldn't do. And in the treatment of patients, that's not tolerable. So it was that spirit of excellence that she instilled in us, I think, that was so important. She's still alive, by the way. She's now 91 years old. She lives in Cincinnati. And I've talked to her. Her mind is still as keen almost as it was then. Obviously, we all fail to some extent when we're 90, if we get that age. But she's still very sharp. Now, Dr. Evans wasn't really along in the department for a long enough period of time for me to develop a lot of loyalty to him. I was young. He was near retirement when I went on staff, but he actually gave me my first job. But I think at the instigation of Dr. Benson. Now, when Dr. Evans retired, then Ellis took over, Ellis Benson. And at that point, Dr. Benson was fairly well known around the United States. He had a national reputation as a clinical pathologist. But he was on the threshold of his career as a national figure. And then over the next 5 or 10 years, he gradually became more and more well known around the country. And then sometime in the mid-70s, and I'm not sure the exact date, there was a move to unite what I referred to previously as the anatomic department and laboratory medicine. And Dr. Benson was given the task from the dean's office to bring the two units together so they would be a combined unit. Now, each unit individually was very good. Laboratory medicine was probably a little bit better than anatomic pathology, but they were both very reputable departments. So Dr. Benson began to investigate the possibility. He talked to the various important figures in each department to see how they felt about it. And like all changes, there were negative and positive feelings about it. But I think the majority of people in both sections favored a unified department. So each section then voted to determine whether they wanted to go together. And the vote was positive in both areas, so the departments were unified. Now, after the departments were unified, the department was a blockbuster department in the United States. It was clearly in the top 5, if not number 1. A lot of people would rate it number 1. I think that's very difficult to do when you yourself are inside the department. I mean, you don't want to go around saying we're number 1. But I think in retrospect, we were either 1 or 2 or 3 or somewhere in that, and it doesn't make any difference because 3 is as good as 1, and probably 5 is just as good as 1. But we were a well-known department around the United States at that point. Unfortunately, there are some downsides to that. And I think one of the downsides is we became arrogant. And I think that's always a danger of achievement. They become arrogant. Humility was not a part of our department at that point. It was a rather foreign word, I think. And Dr. Benson might be surprised to hear me say that. But we were arrogant. And it led to some bad feelings among other departments in the country. When we recruited new residents, we kind of made them feel like we are doing you a favor by interviewing you for a residency. And some of the residents picked up on this right away. And I think I was personally responsible in one instance for this attitude. And it hurt our recruiting for a while because I think we got this reputation of being arrogant in that unless you were really something, you couldn't get in Minnesota. And it wasn't true because we selected people that we thought would be fit into our program, I mean, as we had it established. Because it's from the residency that you really recruit your faculty. And most of our faculty at that time were in fact out of our own residency program. I mean, me for one, but almost everybody in the department. We didn't have to go outside, so to speak. So I would say that during the 70s, 80s, Dr. Benson's leadership really clearly guided the department. I mean, it made it the national powerhouse that it was. Now, simultaneously, almost with the unification of the departments, but a little bit prior to that, I'm giving you a little bit of history you may not want. Dr. Benson had recruited a new group of surgical pathologists, which is kind of the backbone of the anatomic pathology department. And if you don't have good surgical pathologists, you don't have a good training program, and you don't have credibility from the surgical staff. And he recruited a young surgical pathologist who had been out of his training for about 4 or 5, 6 years down at Washington University in St. Louis, Barnes Hospital. His name was Rossi. And it was well known around the country that Dr. Rossi was becoming one of the most prominent surgical pathologists in the United States. And for some reason or other, he felt maybe it was time to leave St. Louis. And Dr. Benson flew down there to talk to him, try to convince him that maybe it wasn't as cold in Minneapolis as he anticipated. And after about several months, he was able to recruit Dr. Rossi and a whole team of surgical pathology. And when they came to Minnesota, that solidified the reputation of the department. No question about it. Dr. Rossi was an intellectually gifted individual and a remarkable surgical pathologist. As a matter of fact, he's probably one of the top 3 surgical pathologists in the world right now. There was a famous textbook of surgical pathology out of Barnes Hospital. It was originally edited by Loren Ackerman. And when Dr. Ackerman retired, he turned it over to Dr. Rossi. So it's now Rossi's surgical pathology. And it's one of the surgical pathology in the United States. And he was here for about 8 years. And for personal reasons, he left the institution. But they 8 years, I would say, was the pinnacle of the department's success. Okay. I became a personal friend of Dr. Rossi's. To me, he was a wonderful colleague from whom I learned a great deal, even though he was the same age as I was. And it really, as I said, if we were already a superb department, we were, as I say, a blockbuster department after Rossi came on staff. We had Benson on one side in laboratory medicine, and we had Rossi on the other side. And it was a remarkable combination. So after Juan left, then we did, as I said, we moved on. Eventually, Dr. Benson began to think about retiring, and there was an interval period in which he was on sabbatical. I took over the department as acting interim chairman. And then when he came back from sabbatical, I remained on as interim chairman for about a year. And then he resigned, and then the recruitment process started, and I was interim chairman, during that extended period then. So it kind of interfaced from Dr. Benson's going on sabbatical, then returning, and then resigning from the department. And Dr. Benson's loss was, of course, once again one of the more serious points of the department, because he had been an excellent leader during that period of time. So it was a matter then of going on to a new leadership. And then they selected Dr. Furt, who I thought was a very good choice. He has a lot of charisma. He's able to do things and get things done and more or less continue the spirit of Dr. Benson. But no two department chairmen are the same. And it would be pretty hard to totally emulate Dr. Benson. It was his manner of being able to screw you and smile at the same time and make you feel good about it. My major concern with Dr. Benson, which he well knows about, is the salary scale, and I guess that's that was a problem in every department, in every school in the country, that you think the chairman should be a little more generous with his salaries, not only for me, but for other people in the department. But there's a limited supply of money. And with the money that he had, he did an excellent job. Both at recruitment and trying to be fair with the individual faculty members. Now, along the way, there were other colleagues. It'd be remiss if I didn't mention one of my own trainees, Dr. Rob McKenna, who came on staff in about 1978, and was a colleague of ours for probably about 15 years. And it was during the time that Rob was in the section that we did a great deal of our writing, and it was usually the two of us wrote together. And we published quite a bit during that period of time. And then he was recruited to Southwestern University, University of Texas, Southwestern in Dallas. And he went down there as vice chairman, which he is still his present position today. And I was just thinking, because I see Rob very frequently, and there's about 9 years difference in our ages. It wasn't all that much different. Which probably was a great deal of help, because we were, in a sense, contemporaries, in the development of the hematopathology section. And that was, as I said once again, during the 70s and 80s, which I identified as the golden period in the department. It was just a remarkable intellectual experience, one which will never be duplicated. I remember after I had been in school, college for 4 years, and medical school for 4 years, and at the few-month interval between medical school and internship, I had a fair amount of free time. I remember going to a movie with a friend of mine, and there was a program called, they showed a program called Dick Clark. And I said to my friend, "Who is Dick Clark?" He said, "You're joking." And I said, "No, who is he?" And he said, "Well, he's very well known. There's a television program with Dick Clark." I grew up in the non-television era. When I was in college in Grand Forks, we had no TV. When I was in my second year of medical school, TV was just beginning to be introduced in North Dakota. There was one station in Fargo, and the reception in Grand Forks was very poor. During internship, I had no opportunity to watch television. I mean, it just didn't exist. And I didn't have it. I couldn't afford a television when I was a resident. it was just one of the items that, you know, I didn't budget for. So I didn't have my first television set till 1968, long after television had been in existence. And by that time, I had not developed any enthusiasm for watching television. So to this day, I almost never watch television. The only time I watch it is when I visit some relatives. And on Sunday afternoon, we will often watch the news or some sports event. Other than that, I did watch TPT the other evening, Channel 2. The Minnesota Orchestra was being broadcast from the London Proms. And I thought it was an opportunity to see them, you know, on site at Albert Hall. I've been there, and the Albert Hall is a gigantic place. There are 6,000 seats. Northrop is 4, so you can imagine this is bigger than Northrop. And there are many tiers. And when Sunday, I had been coming back from Dublin, and I was in London for 3 days. So I thought I'd go over to the proms. And I had to go up to the top level, which was almost a rarefied atmosphere. But the enthusiasm of the audience was just remarkable. I mean, they lose all of their inhibition, so to speak. And they're very enthusiastic. But it was a great experience. I mean, musically, I thought it was okay. A hall of that type, the acoustics are dreadful. But the experience of being there was well worth the money that I paid for it, is all I can say. So I wanted to see what the Minnesota Orchestra was like, so I did watch television. But in general, I don't watch television. In the programs I have seen, I consider to be so trivial and almost demeaning intellectually. You know that? Some of these sitcoms, or whatever they call them, they're insulting, I think, to intelligence. I think one of our problems with education, particularly in high school and maybe grade school, is that the children come home from school, they don't study, they turn the television on, they either play video games or they watch these inane programs from which they are not going to get any benefit intellectually. And we talk about spending more and more money for education, and yet I think for every hour of education, we get 3 hours of television, which totally negate the advantage of 1 hour of education. Or maybe it should be for every 3 hours of education, 1 hour will negate it. I mean, and we wonder why they don't achieve on their test scores. I mean, why does that happen? Or why don't they seem educated? And the parents blame the school board, and they blame the teachers. But in fact, the individual to blame are the students and their parents. I mean, when we got home from school when I was a kid, and I came from a lower middle class family, I mean, that's being generous. We studied from about 4 in the afternoon till what we called supper time. And after, we maybe listened to 1 or 2 hours of radio programs, and then we studied again until we went to bed. And this wasn't a routine that was considered punitive. It was just a matter, this is how it's done. My parents never said, you got to go study now or do this. It was just a matter that we went home, we studied. And of course in Grand Forks, there's not a great deal to do. There may be more to do now, but there were no malls, no shopping malls. The major entertainment in the wintertime was an ice skating rink, usually in your backyard or a neighbor's backyard. So you might go out after supper and skate for an hour and a half, till your feet got cold, and then you would come in and you would study. In the summertime, there were more options, obviously. I mean, we could go swimming or things like that, play ball. But in the wintertime, no skiing because there are no hills. It's about as flat as a tabletop. But the ice skating was predominant sport. And there wasn't a lot of money for entertainment, by the way. I mean, that was another factor. But even I think the children who were from wealthier families, I mean, their routine was very similar to my own. And so there wasn't the opportunity to dwindle away your time as it is being done right now. What is a way to get through college and what's a way to get through medical school and internship and residency? William Osler, who is well known now to be one of the most famous physicians in Western medicine, was once asked, what's the magic word in medicine? And he said the magic word is work. And in order to get through high school, and the way to get through college, and the way to get through medical school and be successful is hard work. And today, I think it's enormously easier to learn because of the internet. I mean, there's no question that the knowledge accessibility would be beyond our comprehension back in the 50s. You can just type in a subject matter and you're suddenly overloaded with information. This was not available to us. And I often wonder what it would have been like to be able to sit down at a desk and get all that material that I used to wander over to the library to get. And I can remember spending hours in the library going through the Indicus Medicus to find articles that I wanted to review for a paper or something of that type. And nowadays, all I have to do is type it in. I get this tremendous bibliography. And so that makes it easier. But studying is not easy. Studying is hard. And you can't just take a chip and embed it in your brain, and know everything right away. Learning a language, I think, is extremely hard, particularly for adults. For young children, relatively easy. But in college, I think that learning a language, a second language, is just hard work, unless you're one of these gifted individuals who has the ability to acquire a language very readily. I think the same thing is true for mathematics, physics, chemistry, biochemistry. So you can't go to medical school and expect to learn just by osmosis. You have to go home, sit at the desk, and read the books or get on the computer to get this source of information. And there's no substitute for work. I agree completely with what Osler said. It'd be pretty hard to disagree with Osler, but I think he hit it right in the head. The magic word is work. And I think if you're starting out in high school and you want to say, I want to be a doctor, first of all, I can't think of a more noble profession. I hate to use the word noble, but I really view it that way. A more noble profession than medicine. Because I think the motivation to be a doctor is very similar today as it was back in 1930 and 1940. And you want to help other people. Today, I think the opportunity when you are a doctor to help other people is enormously greater because of the advances that have been made in medicine since 1930. Now, today we talk about somebody gets a sore throat, strep throat, we give them penicillin or penicillin derivative, and they get better. Or they have an arthritic problem, we give them steroids and they get better. Athlete has trouble with his pitching arm. Pitcher, we just inject steroids and he gets better. When I started McGill in 1957, steroids had only been introduced clinically for about 5 years. And the clinicians there told me when it came in, was first introduced, they were astounded at the results. And I remember grand rounds in the internal medicine department here. They talked about penicillin. And Dr. Wesley Spink was an internist at the university for many years. And he was a well-known infectious disease individual. As a result of that, he was given some of the trial samples of penicillin. And he spoke of a patient who arrived in a hospital late in the afternoon, extraordinarily ill with, I think, meningitis. And he and Dr. Watson, who was in chairman of the department, got together and said, this is a patient on whom we could use this new drug. You know, they didn't know how it worked, but they had some idea of the dosage. So they decided to give this patient this new drug, penicillin. And they started that afternoon. In the middle of the night, Dr. Spink called the hospital, called the ward to see how the patient was doing. And the nurse said, he's doing better. And he was, prior to that time, he was extremely ill, I guess almost comatose. And by morning, he was showing definite signs of improvement. So this was in our contemporary period. I mean, penicillin, you know, was first introduced during the Second World War. And it wasn't used in the civilian population. It was used sporadically in the armed forces. And it was after the war. So we're talking about 1946, 47. The advances that occurred in late 47 were almost as important as the advances we're seeing today. I mean, the introduction of antibiotics, which made so many things safer, particularly surgery, and the use of steroids. I mean, these were extraordinary advances that weren't totally appreciated at the time. But by the 50s, when I started at McGill, 57, it was well established, the importance of these. And the clinicians there told me about these very exciting periods when these new drugs became available. It just changed the whole scenery in medicine. And today now we're on almost a continuing threshold of new observations and new treatments. So I think for a student who wants to go into medicine, it's extraordinarily exciting. I wish I were starting all over again. I mean, I often talk to contemporaries of mine, and we all agree that medicine is totally different today than it was in 1955 when we started out. In that, although there's a great deal more to learn, there's so much more you can do. And I mean, the ultimate purpose in medicine is to make the patient better. You may not always cure them, but at least you may make their life a more livable situation. So, would I do it over again? Yes, no question about it. I mean, it was just a wonderful experience. I mean, very hard to duplicate. There may be other professions, I mean, that are similar. I don't know. I don't think so. Not for me, there wouldn't be anyway, I can tell you that. You know, medicine is you don't suffer financially. I mean, but it's not the profession where you're going to get real rich. I mean, if you want to be really rich, go into law school and get involved in financing or something like that. I mean, the extraordinary amounts of money today are being made by immoral CEOs and financiers, and they work together. But medicine, you know, you always used to hear about the rich doctors. Right now, the monetary reward in medicine is really not all that outstanding. I mean, If you work for an HMO, you get paid generously, but it's not outstanding. I mean, when you compare it to other occupations. So if you're going into it for the money, forget about it. I mean, but if you're going into it for the personal experience and the feeling of accomplishment, there's no substitute.